Dear colleagues, this is a cataract with Coloboma iris. I have started the case. Let us see how the surgery proceeds. By this time, all the incisions have been made, and at present, hydrodissection is being done after capsulorhexis. Hydrodissection should be very good in such cases. In patients with Coloboma iris, sometimes there is jonular dehiscence at the site of coloboma. Fortunately, this case was not like that. The granule was okay. So after hydrodissection, a nuclear rotation has been done. Now viscoelastic substance is injected into the antechamber. Now we are going to go into the eye with the Phaco handpiece. This is APPA Galaxy CV1 machine. This machine is no longer in production. I bought this machine long back, about 15 years, 16 years ago, and it is still functioning very well. And this is horizontal chop. The Phaco power at this time is 60%, flow rate is 40 ml per minute. The machine allows only this much, 40 ml per minute. And I have seen that if I work with the maximum flow rate, the followability becomes good. And now the vacuum was only 160. By this time, one half of the nucleus, that is a heminucleus, has been taken care of. It has been emulsified and removed. This is the other heminucleus. It is divided into two parts, and each part is emulsified and taken out. Now see what happens in this case. When I was emulsifying the last bit of the epinucleus, I caught the posterior capsule and the reflux of the machine was not working. So I asked my assistant to squeeze the aspirating tube and create reflux. We are going to see that in a very short while. Look at here. Yes, I've caught the posterior capsule. I'm asking my assistant to squeeze the aspirating tube, and she has done that, and the Phaco tip has released the posterior capsule, and I have not caused any precedent. So if we can react at the right moment, if we can respond at the right moment, we can prevent precedent in many circumstances. Now this small elongated piece of epinucleus can be removed by through the main incision. I'm sure about that. So viscoelastic substance has been injected, and I go into the eye with a Simcoe cannula. I align this epinuclear fragment in such a way that it comes out through the main incision. Here it is. I just depress the posterior lip of the main incision and it comes out. Now I clean the cortical cleanup is done by this Simcoe cannula. I can respond better in mid-dilated people. I can work very well with Simcoe cannula, and I'm less comfortable with bimanual IA when the pupil is not fully dilated. When I can't see the cortical matter, I can work better with the Simcoe cannula, and if you are comfortable with the bimanual IA, that's a great thing. Now I go through the side port, which is on the left side of the main incision, and I remove the sub-incisional cortical matter. Then I inject viscoelastic substance in the antechamber, in the capsular bag, and this is a hydrophobic acrylic intraocular lens. This is Envista intraocular lens, which takes a very long time to unfold. Probably the longest time that is taken by an intraocular lens to unfold is this lens, Envista by Bausch & Lomb. Other lenses from Alcon unfolds very fast. Acryol from IO Care also unfolds very fast. But this lens takes the longest time to unfold. So I have taken help of the Sinskey hook and I have placed both the haptics in the capsular bag, and the haptics have taken shelter at the equatorial region of the capsular bag. Now, in Coloboma iris, the superior margin of the pupil, when the pupil is not dilated, almost covers the optical center of the lens, of the crystalline lens, and when the intraocular lens has been placed inside the capsular bag, the optical center of this intraocular lens is going to be partially covered by the superior margin of the iris of the pupil. So in such cases, what I do is I do superior sphincterotomy. Sometimes I do superior sphincterectomy using a vitrectomy cutter. In this case, I have removed the viscoelastic substance from the behind the IOL, and now I am removing the viscoelastic substance from the front of the IOL. Now I thought in this case I will do superior sphincterotomy. I'll just cut the sphincter, just make a small cut at the pupillary margin. I'll go through the side port which is on the right side of the main incision. I inject a little bit of viscoelastic substance, go through the side port which is on the right side of the main incision. Here it is. I make a very small cut, and that's it. This will cause enough elevation of the superior margin of the pupil, and the optical center of the intraocular lens will be free, will not be covered by the margin of the pupil when the pupil is not dilated. And now the case is almost over. Thorough cleaning of viscoelastic substance has been done. I inject a little bit of moxifloxacin underneath this air bubble, hydrate the side ports, and form the antechamber and conclude the case. This idea of superior sphincterotomy, this one, works very well, and patients will adapt to this new situation like a patient adapts to a toric lens very well. Thank you very much for watching the video. Hope this will help you in your practice.